are delighted to share with the Clinical Journal of the American Society of Nephrology audience the results of our study entitled Risk of Urinary Tract Infections with Sodium Glucose Transport Protein 2 Inhibitors in Subpopulations with Abnormal Genitourinary Pathology. The impetus for the study really evolved out of some interesting discussions we had in the Veteran Affairs Chronic Kidney Disease Clinic. One of the fellows presented a case of a veteran with a spinal cord injury, paralysis, chronic kidney disease from diabetes, multiple prior urinary tract infections, and a suprapubic urinary catheter. The patient was on an ACE inhibitor, but we weren't really sure whether to add an SGLT2 inhibitor as well. I honestly didn't know what to do. I remember the case was presented to me just before the 2023 ASN conference. Then at the American Society of Nephrology conference, I attended one of those lunch and learn sessions. Stephen Coca moderated it from Mount Sinai. The session was packed, standing room only. I didn't get any lunch, but that's okay because the session was still great. And in his introduction, Stephen Coca proclaimed something to the effect of, ask not who you can give an SGLT2 inhibitor to, but instead ask who you can't prescribe an SGLT2 inhibitor to. He did it much better than I did, but it was kind of a John F. Kennedy style moment and everybody loved it. In the subsequent talks, the speakers discussed several populations for which we needed more data: type 1 diabetics, pediatric patients, malnourished cancer patients, and more. But patients with genitourinary tract abnormalities didn't come up in the session. And it's the same thing when you look at the KDIGO guidelines. Genitourinary tract abnormalities are not really discussed.
So you were not able to find the guidance for your own patients.
Yeah, that's right. And that's why I pitched this idea to you.
Yes, I remember liking the idea. My research group is very interested in comparative risk, and this is the perfect type of question. SGLT2I have great benefits like improving blood glucose control and protection against chronic kidney disease and cardiovascular disease. But you have to weigh those benefits against the risks.
Yeah, unfortunately, a significant portion of veteran patients with chronic kidney disease also have genitourinary tract abnormalities. As both SGLT2 inhibitors and genitourinary abnormalities are linked to urinary tract infections, nephrologists and primary care physicians are not always confident whether to start an SGLT2 inhibitor in these patients. I actually found one smaller study that stated we should just use GLP-1 receptor agonists instead in nursing home populations to avoid urinary tract infections altogether. Clearly, we needed more data. Both glucagon-like peptide 1 receptor agonists and SGLT2 inhibitors can be used to manage diabetic kidney disease. In this study, we aim to derive real-world observations for the comparative risk of two types of urinary tract infections, Candida and non-Candida, between the two drugs, SGLT2 inhibitor and the GLP-1 receptor agonist. We placed special awareness on patients with genitourinary abnormalities. We included 270,000 users of either SGLT2 inhibitors or GLP-1 receptor agonists from a United States nationwide insurance claims database under an active comparator and new user design. And then we conducted a time to event analysis. Pengyu, can you tell us a bit more about these statistical analyses?
Yeah, we included new users of SGLT2I and GLP-1RA without any urinary tract infection in 30 days prior to exposure. We follow the user until discontinuation of drug exposure. We define the outcome as times from drug exposure to diagnosis of Candida UTI and non-Candida UTI. We controlled for age, gender, race, other anti-diabetic drug exposure, comorbidities, and GU abnormalities. We use both a covariate-adjusted Cox model and an inverse probability of treatment-weighted Cox model.
Thanks, Pengyu. I think a really important aspect of this study is how we were able to separate Candida UTI from non-Candida UTI as an outcome. A lot of studies don't do that. Zhang, I know we then used Cox models to estimate the hazard ratios of urinary tract infections in the whole population and in patients with genitourinary abnormalities. What do you see as the highlight of our findings?
So we observed consistent findings in all Cox models, as well as in the whole study population and in patients with GU abnormalities. In short, SGLT2 inhibitor exposure compared with GLP-1 receptor agonist exposure was associated with a greater risk of Candida UTI, but actually a slightly lower risk of non-Candida UTI.
I think these are important findings for clinicians. SGLT2 inhibitors compared with GLP-1 receptor agonists conferred a greater risk of Candida UTI, but not non-Candida UTI. In individuals with abnormal genitourinary pathology, the comparative risk of non-Candida UTI, likely bacterial urinary tract infection, was not greater in those administered an SGLT2 inhibitor compared to GLP-1 receptor agonists. Genitourinary abnormalities were associated with greater risk of Candida UTI, and SGLT2 inhibitor initiation conferred an additive, larger risk of Candida UTI in the subpopulation compared to GLP-1 receptor initiation.
So, Mike, last question. Now that you know all this, would you prescribe an SGLT2I to your veteran with the spinal cord problem and the suprapubic catheter?
Yeah, that still depends on your risk tolerance. To me, it was reassuring to know that the risk of bacterial or non-Candida UTI didn't increase in these fragile patients. Before the study, I worried that most worrisome thing would be that we would induce bacterial urosepsis with an SGLT2 inhibitor in patients with a neurogenic bladder or a neobladder, radiation cystitis, or otherwise who had a high propensity for urinary tract infections. But we didn't see that in the data. Thus, the study opens the door to a shared medical decision-making conversation about mitigation of CKD progression versus fungal urinary tract infection risk with our patients. In patients with good life expectancy, it might make sense to use an SGLT2 inhibitor.
Yeah. Thanks everyone, and thanks to the support from the editorial staff at the CGASN. Their critiques really help this study to become the best version of itself.
Thank you, everyone.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.